Hi, and thank you so much to Medasense for inviting me to this presentation today. My name is Coeckelenbergh, and today I'll present to you a very interesting topic. Can we predict and individualize anti-nociception with NOL? I have a few potential conflicts of interest. I'm associate editor at BMC Anesthesiology, and I've had support from the following companies and organizations in different forms. Now let's dive into the topic because anti-nociception is important. We are too often there where patients receive either too little or too much anti-nociception and are at risk of developing perioperative complications, and should be here where patients quickly get up and go home with a positive experience of the perioperative care. Now, as a quick introduction, I think we can all agree today that nociception is the unconscious response to a nauseous stimulus, and it is often characterized by sympathetic stimulation. This gives us an objective way of measuring the patient's response to nauseous stimuli. Often what we do is we measure heart rate and blood pressure, but the NOL is much more elegant, and it integrates a variety of factors to give us a measure of the autonomic tonus of the patient as a surrogate to nociception. It allows us to see if the patient responds or not to nauseous stimuli. And is measuring this autonomic tonus important? Well, of course it is, because if we don't measure it, and if we don't maintain a stable tonus and a stable response to nociception, we risk hemodynamic instability. Now, no article shows this more clearly than the Meyer study published last year in Anesthesiology, where they showed clearly that the NOL leads to a decrease in remifentanil, but also a decrease in hypotension, which in my perspective is very interesting. Why? Because hypotension is dangerous. Now, there are clearly no fixed definitions, but it's been agreed upon that a personalized threshold may be the best goal, and certainly too low a blood pressure is bad. In addition, the sympathicolytic activity of our drugs is a frequent cause of hypotension. Opiates associated with inhaled ethers or with propofol often lead to hypotension. Now, this is just one of the many studies that have investigated hypotension in the perioperative period, and they show clearly that for both acute kidney injury and myocardial injury, the deeper the hypotension and the longer it is, the increase in risk of developing these complications, both of which have been associated with increased mortality. Now, is NOL a possible solution to this problem? Well, maybe, at least part of the solution, if we personalize anti-nociception and maintain autonomic tonus. Now, how do we personalize anti-nociception? Well, it's simple. You just need to maintain the NOL and target. Keep a target of 10 to 25. Now, again, I have to go back to Meyer's study because it was so elegant and clear how they did this. They applied a personalized NOL anti-nociception goal, maintaining the NOL between 10 and 25, which led, yes, to a decrease in remifentanil, but also to a decrease in sympatholysis, an individualized autonomic tonus, which was associated certainly with less vasopressors, but more importantly, with a decrease in hypotension. Now, if you look at the data, it's clear. For intense hypotension less than 55 millimeters of mercury, there's a significant decrease in hypotension in favor to the NOL group. And again, this threshold of 55 millimeters of mercury has been shown time after time after time to be associated with increased morbidity and mortality. So, will personalizing anti-nociception with NOL improve outcome? Probably, if it leads to improved hemodynamics, and future outcome studies are needed, especially multi-center randomized controlled trials. So we've quickly talked about personalizing care by having reactive algorithms. We see, for example, that the NOL is at 39, so we increase our opiates, or on the other hand, if it's below 10, we decrease them. But what if we could move from reactive to predictive? Now, how would we go about doing this? First, we need to go back to the basic concepts. Each patient is different, right? That's the main concept behind personalization of care. And a response to a nociceptive stimulus can vary thus from patient to patient. So if every patient varies, what do we need? We need a standard stimulus to allow us to assess each individual change in nociception. And what better monitor, or at least elicitor of a nauseous stimuli, than the tetanic stimulation, which all of us have already used in our care to assess neuromuscular blockade, right? Whenever we're not sure if the patient is still paralyzed, we often apply tetanic stimulation. Well, it's not only useful for assessing neuromuscular blockade, it's also been shown time after time to be useful in assessing nociception. And it's even corresponding to the direct intracutaneous stimulation of pain fibers. So not only is it safe and readily available, but it is also a good measure of nociception. So Professor Barvet from Erasmus had this great idea of testing the NOL response to a standard noxious stimulus, the tetanic stimulation, in different patients to see if he could predict the level of remifentanil necessary for incision. So how did he go about doing this? First of all, in this small abstract published last year in Anesthesia, the aim was to determine if the response to a standard stimulus can predict optimal antinociception for incision. And the strategy was simple. They analyzed the change in NOL index to tetanic stimulation. What they used was a simple neurostimulator, which applied a 0.5 milliamp, 100 hertz, 30-second tetanic stimulation. So a little longer than what we usually use, but still it's the same tool. And the population was cardiac and thyroid surgery, which allowed us to have a large range of remifentanil effect site concentrations at incision. And the outcome comes back again to personalization of autonomic tonus. The idea was to have hemodynamic stability defined as heart rate and mean blood pressure within 20% of the awake baseline values. Now, how did they go about doing this? They applied remifentanil propofol anesthesia and maintained remifentanil at 4 nanograms per milliliter in the BIS between 40 and 60. They applied a tetanic stimulation and assessed the change. If it was greater or equal to 20, they increased the effect site concentration and repeated the test. On the other hand, if it was less than 20, they decreased the effect site concentration and repeated it. Their goal was to find the lowest effect site concentration of remifentanil for minimal change in NOL index, less than 20, and they incised at that concentration. So what did it give? Their results were pretty compelling. At incision, heart rate remained in target for all patients. I mean, how many of you guys actually have patients that don't develop tachycardia from time to time at incision? It's something that's relatively frequent. Even with 15 gammas of sufentanil, you could have tachycardia. And only one patient required vasodilator. Again, results that I find pretty impressive. Furthermore, and this is very interesting, they found a linear relationship between the change in NOL index and the optimal remifentanil effect site concentration. As you can see, not only did they derive a formula, but the stronger the change in NOL index, the higher the remifentanil you need for incision. So, the change in NOL index has a linear relationship with remifentanil requirements at incision, right? Is there room for improvement? Well, of course, there's always room for improvement. What if we just use one tetanic stimulation? So again, the same study situations. Propofol remifentanil TCI, BIS between 40 and 60, and the effect site concentration at 4 during the test. We apply tetanic stimulus, assess the change in NOL, but this time we use the formula derived from the previous population to give us an idea of the optimal effect site concentration for incision, and we incise at this concentration. So we have a study that we'll soon submit, but let me just give you a case report from this study of an 80-year-old female patient undergoing CABG surgery with a preoperative mean of 82 and a heart rate of 60. Again, it's the same anesthesia conditions. Propofol, remifentanil TCI, with the remifentanil effect site concentration at 4 and the BIS between 40 and 60. After the test, of course, we decrease the remifentanil concentration in this patient to 2, and we maintain a norepinephrine infusion to keep the patient in their baseline targets. So we apply this tetanic stimulation after intubation and after a period of no touch. And we see that the change in NOL index is 20. So from the formula of the previous population, we derive that the effect site concentration should be 5.1. Now, as everyone knows, cardiac surgery takes time to prepare. The surgeon has to arrive, and then the team has to prepare the drapes, etc., etc., etc. So it takes time. During that time, of course, we decrease the remifentanil to 2, keep BIS between 40 and 60, and we have to, in this patient, give some norepinephrine up to 4 micrograms per minute. But 1 minute before incision, we stop the norepinephrine drip, we wait, we set the effect site concentration to 5.1, and we evaluate the patient's hemodynamics after incision. And what do we find? We find that mean blood pressure is 91 and the heart rate is 57. In other words, we maintain the patient's blood pressure and heart rate within 20% of the patient's baseline values. So, predicting nociception. Although it's still in the preliminary phase, we do have some promising results. And it may improve hemodynamics and decrease vasopressor needs. Are there future directions for predictions? Of course, we need prospective randomized controlled trials, always. But think about this. Wouldn't this be nice for the next NOL index, for example, on the PMD 300 platform, to integrate a noxious stimulus into its platform? Like that, it could give you an automated calculation of the incision antinociception. Wouldn't that be nice? And then there are other future directions that we can use with the NOL and personalization of care. How about evaluating the effects of multimodal antinociception? Let's talk about dexmedetomidine. Is dexmedetomidine a friend or a foe of the NOL? Well, to answer this question, we need to go back to the basics. The NOL index measures sympathetic response, right? But many drugs affect sympathetic response. Some stimulate it, such as ephedrine or phenylephrine. Others inhibit it, such as opiates and alpha-2 agonists. How do these drugs affect the NOL index? Do they increase it in the case of stimulants? Do they decrease it in case of inhibitors? I recommend that y'all read Philippe Richeb's article on phenylephrine, but today we're going to focus on dexmedetomidine, because dexmedetomidine should theoretically decrease the NOL index because it has both sympathicolytic activity and anti-nociceptive effects. So we designed a study to test this hypothesis. And in this study, we tested the infusion of dexmedetomidine during rimifentanil propofol TCI anesthesia, where one group received dexmedetomidine in addition to the rimifentanil propofol, and the other group received a placebo, sodium chloride, in addition to rimifentanil propofol. And the aim was to determine if a low-dose infusion of dexmedetomidine would affect NOL index signal and lead to a decrease in rimifentanil need. The intervention was simple. For the first 30 minutes after induction, we set up a 0.6 microgram kilogram drip of dexmedetomidine over 30 minutes, and then switched to a 0.6 microgram kilogram hour drip until 30 minutes before the end of surgery. And the other group, they received an infusion of placebo, 0.9% sodium chloride. And the anti-nociceptive strategy was also simple, maintaining the NOL between 10 and 25 by modifying effect site concentrations as required. For propofol, the same thing. In both groups, we had a modification of propofol to maintain the frontal EEG, either BIS or entropy, depending on the study center, to maintain the EEG between 40 and 60. So what did we see? We saw some pretty compelling results. In the 32 patients that received dexmedetomidine in addition to propofol and rimifentanil versus the 26 patients that only received propofol and rimifentanil, we saw a statistically significant difference in the amount of rimifentanil needed. So there was less rimifentanil required in the dexmedetomidine group. In other words, dexmedetomidine was an agent that spared opioids. But not only that, we also saw that there was a significant decrease in propofol requirements in the dexmedetomidine group. Now, this has been shown already in the past that with frontal EEG, propofol requirements decrease with dexmedetomidine. But here we showed that the NOL is affected and leads to less infusions of opioids when we add dex. So in conclusion, dexmedetomidine decreases intraoperative rimifentanil requirements during NOL-guided antinociception. And EEG and NOL monitoring can measure its effects both on the hypnotics and the nociceptive response. In other words, coupling these two monitors together allows us to personalize multimodal anesthesia. Now, I want all of you to go home with the following key messages. First of all, personalizing antinociception is feasible with the NOL. Secondly, predicting optimal antinociception for incision is a potential strategy to decrease vasopressor use and maintain the patient's autonomic tonus. And finally, a multimodal approach that combines opiates with dexmedetomidine is a promising approach to individualize antinociception with NOL. I would like to give a special thanks to Medasense and the whole Medasense team for helping us and inviting us today, and also Professor Barvet, who has introduced me to research on nociception, the NOL index, TCI anesthesia, and of course, cardiothoracic anesthesia. Thank you, Professor Barvet, and thank you very much for all being here.